Hello again, this is Professor Lawrence, and today I'm going to be going over the most basic review of mechanical ventilation. I will be going over the modes and settings that you may find during mechanical ventilation of your patient, and just a couple of troubleshooting facts with alarms. So let's get started. First, we need to figure out what are the indications for mechanical ventilation. Why do we do it? There are a couple of reasons. First is airway compromise. If the airway patency is in doubt, or they might be at risk of losing patency, perhaps from injury, anaphylaxis, many reasons. Or if the patient has respiratory failure, it can be hypoxemic or hypercapnic. Hypoxemic is when the patient has an arterial blood gas value with a PaO2 of less than 60 millimeters. The hypercapnic respiratory failure is when the patient has a PaCO2 of greater than 50 in an otherwise healthy individual. This can be termed ventilatory failure. It's caused by an increased WOB, or work of breathing, poor ventilatory drive, or muscle fatigue. Again, more indications for mechanical ventilation. If you feel that the patient needs their airway protected, perhaps they have lost their gag, sneeze, or cough reflex, sometimes after anesthesia is when this can be exhibited. Contraindications are very clear when a patient's desire not to be resuscitated has been expressed and is documented. This would be in the advanced directives. Types of ventilators. You will notice at a facility where you work that ventilators may be quite different than what you would see at our current facility. Here's an example of one, and here's an example of another type. They vary in their settings where the buttons are located, but I will be going over the basics that you would be seeing on an NCLEX exam and what a nurse generalist should be familiar with. Now we're going to look at the modes of ventilation. This refers to the method of inspiratory support. Here are some examples for you. First is the control mode. This is a volume-dependent mode where the ventilator delivers a preset tidal volume at a preset rate and a preset flow. The patient cannot generate any spontaneous breaths, volumes, or flow rates in this mode. It is the least used of all modes, as the ventilator will lock out the patient's own inspiratory effort, which is not desirable. The next is assist control mode. It used to be called continuous mandatory ventilation. It's also a volume mode as well. This mode, like the other one, delivers preset tidal volumes, preset rate, preset flow rate. The patient, again, cannot generate spontaneous volumes or flow rates in this mode. It is the most common, as the vent does respond to the patient's own effort, which is a good thing. Next, we have synchronized intermittent mandatory ventilation, sometimes just called intermittent mandatory ventilation, SIMV, also a volume mode. This delivers a preset number of breaths at a set volume and flow rate. It does allow the patient to generate their own spontaneous breaths, volumes, and flow rates between the set breaths. It detects a patient's spontaneous breath attempts and does not initiate a ventilatory breath, so it doesn't stack the breaths. This can be used during weaning and is a very common mode of choice. Continuous positive airway pressure, also known as CPAP, is a pressure mode. It can be used two different ways. First, it can be non-invasive. This is where support is given via a mask. Think of your patient with sleep apnea. Or it can be used to determine the readiness to wean. So a patient could still be intubated, but they could be switched over to the CPAP mode. This helps to restore functional residual capacity with a continuous positive pressure in the respiratory cycle. It buys time in heart failure patients and patients with other type of restrictive lung diseases. Now we'll take a look at pressure support ventilation, or PSV. This is a pressure mode as opposed to a control mode. It's used to help a spontaneously breathing patient, someone that does have spontaneous respirations. The settings are applied and they include PEEP, sensitivity, and inspiratory pressure level. The patient inspires a breath. The ventilator gives high flow gas and air to a pre-selected amount based on those indicators above. This type of pressure mode, PSV, can be used in combination with the other control modes that I reviewed previously. Now, one thing that's mentioned in the literature are phase variables. What makes the vent respond? There are three things that are usually talked about: the trigger, the cycle, and the limit. The trigger can be initiated by the ventilator, which is based on time, or the patient can initiate a trigger based on their flow, pressure, or volume numbers. The cycle of the ventilator, inspiration, expiration, by the vent, it's based on time or volume. By the patient, it can be flow or pressure. The limit includes all four of the main indicators: volume, pressure, flow, and time. All of these, volume, pressure, flow, and time, are programmed into the machine. They can be manually triggered with the actual nurse or respiratory therapist making the machine cycle, or the patient's actions are sensed, and that would cause the phase variable to change. So once we get through all of these modes that we discussed, now we need to talk about the settings that are applied. The ventilator needs to be programmed, of course. Respiratory therapists work with the physician to determine the plan. RNs do work very closely with respiratory therapy, but the RNs do not determine the settings on the machinery. There may be algorithms that are in place in intensive care settings, but typically it's respiratory therapy and the physicians, and the nurse's role is separate. First, we have respiratory rate, which is indicated with a lowercase f. This is a type of trigger. The number of breaths the vent will be delivering per minute. It's usually set between 6 and 20. Now we'll look at tidal volume, which is indicated with a capital V and a subscript T. This is also a type of trigger. This indicates the volume of gas and air to be given to the patient with each vent breath. Then we have the I to E ratio. This is inspiratory to expiratory ratio timing. Typically it's set of a ratio of 1 to 2, meaning for every breath in, if it's over a second, it takes 2 seconds to expire. It can also be set usually around 1 to 1.5. If you just think about your own breathing pattern, that will give you an indication of what they're going for with the IE ratio. Then there's an option to apply size to the ventilator. This is like a spontaneous sigh that we do without thinking. It's the volume of gas and air that is put in with the vent breath. It's 1.5 to 2 times larger than the normal amount. It's programmed to happen about 6 to 10 times per hour if the setting is applied. Then we have fraction of inspired oxygen, FiO2. This is the concentration of oxygen delivered by the ventilator to the patient. The amount of FiO2 that is delivered is based on the patient's status, and we collect ABG values and base our settings on that in the overall patient condition. Then there is sensitivity, also called sometimes breathing effort. This is set to detect the patient's pressure or flow with breathing attempts, indicating when or if the ventilator needs to kick in and deliver a breath to the patient. The lower the number, the lower the sensitivity, the easier it is for the patient to trigger a breath, to get one. So if your patient's really weak, they need a lot of help, so the number would be lower. The higher the number, the sensitivity, the harder it is for the patient to trigger a breath. So a patient that's doing better would need less help, so they would have to work a little bit harder to get that breath. Then we have peak airway inspiratory pressure. This is the pressure required by the ventilator to give the set tidal volume. This value is monitored by the nurse and respiratory therapist and physician to track the patient's lung compliance. It reflects resistance to ventilatory support and is monitored throughout the time of intubation. Positive end-expiratory pressure, or PEEP, is talked about a lot in the literature, in your text, and in your resources. This is used in the expiratory phase of respiration. It would indicate a severe gas exchange problem if you need a lot of PEEP. The goal is to prevent atelectasis and to keep lung tissues open and functional. And here's a short video that will give you a visual aid so you can understand PEEP a little more clearly. Now we're going to move on to alarms. And these are the top 2 alarms that are discussed in the text and in the literature: the high pressure and the low pressure. Of course, there are many, many other types of alarms, but if you are not a critical care nurse, that is not something you need to really spend a lot of time on now, memorizing all the alarms. So the high pressure alarm would indicate secretions. The patient has had a cough, they are wheezing, having bronchospasm. The tube, the ET tube, is displaced or blocked. Perhaps it's blocked with water, or it's kinked, or the patient could be fighting the vent. Sometimes they could be biting the tube with their teeth. The low pressure indicator could mean that the vent is disconnected from the patient, or if the patient has stopped spontaneously breathing. Well, what do? First, you assess the patient, not the machinery. Look at your patient, see if they need support now, meaning bagging. Correct the problem if you can. The previous slide, we went through all of the basics. Some things are very obvious. If there's water in the tube, or if your patient's biting the tube, you're going to need to take steps to fix that. In the end, your support is the respiratory therapy department. We are a team. You should not be repeatedly silencing an alarm on a ventilator. You need to get to the root cause of the problem. But remember, we have a respiratory therapy department because they have specialty training. So call them and utilize them. Now, we've had our patient on the ventilator, but at some point we're hoping to wean them off. There are 4 options in the weaning process that are typically discussed, and I'll go through each of these individually. The first is the SIMV, Synchronized Intermittent Mandatory Ventilation, which was discussed earlier in the screencast. If your patient was on more of a dependent mode, this allows the ventilator to sync with the patient's actions. Gradually, the programming on the equipment would shift to less need for ventilatory breaths at set tidal volume. So it would be triggered by the patient's need or lack of need. And it can also be combined, this SIMV, with PSV, that pressure support if necessary. The good thing is they wouldn't be free from the ventilator from the outset too early. The other type is pressure support ventilation, which I just mentioned. The pressure is delivered during inspiration only. The patient controls the length and depth of the respirations. They control their own rate. So definitely more control is given to the patient. There is a gradual decrease of that pressure support during inspiration. Once the physician and respiratory therapist feel the criteria have been met at the institution, then the patient could move on to extubation. Then we have continuous positive airway pressure, or CPAP. Now remember, CPAP is used a lot by people at home that have sleep apnea, but in the hospital on a ventilator, this can be used as part of the weaning process. They remain connected to the ventilator, but the settings are changed and positive pressure is given throughout the respiratory cycle. This is where the patient is breathing on their own spontaneously, and the goal is to see if they can wean over time, many hours typically. But in this case, because they're still connected to the vent, it's easy to switch back to full ventilatory support if the patient needs it. And the last method, which was the tried and true, used over years method, was the T-piece. There is a picture of a T-piece in your Silvestri. The ventilator is disconnected for short time periods, and the patient is switched over to a humidified oxygen delivery through that T-piece, through their trach or ET tube. CPAP can also be applied to the T-piece as well if they want to give that positive supportive pressure. Progressively longer time off the ventilator until they are weaned. The downside is that the patient is completely disconnected from the ventilator during that time, so there is no backup plan. This T-piece method has been usurped by the other types of weaning options that I've already outlined. I wanted to wrap up this presentation by discussing alarm fatigue. In the intensive care unit, staff are bombarded with sounds all day long, and the Joint Commission has found that most sentinel events, meaning death or near-death events in the ICUs with ventilators, can be traced back to alarm fatigue. So if your patient is ringing off again and again and again, you need to get your team together, respiratory therapy and the physicians, and see what can be done to improve the situation. The key is to not become immune to that sound, because one of those times, like the boy crying wolf, your patient really will be having a life and death event. What policies are available in our facility that can help us to have better outcomes for our patients?